Good afternoon, everybody. My name is Rachel Schrader. I'm Vice President of Clinical Care and Education here at Parent Project Muscular Dystrophy. Really glad to have you here with us today. I think one of the things that we've seen a lot in the community over the last several months is questions as they relate to genitourinary health and Duchenne. And I think this is a topic that there's a lot that's unknown, and we have a lot of questions and not a lot of answers. And so we really are looking forward today to bringing together three experts in GU to answer some of these questions, provide some baseline information to the community about what we know about Duchenne and GU, and see where we can take this information to ultimately improve how we think about and care for folks with Duchenne. So with that, I will go ahead and let us get started. So quick housekeeping tip, if you have questions, please submit them through the chat function. We're going to hear from each of our speakers, and then during the last probably 20-ish minutes of our time together, we'll get into those questions. So as you think of your questions, throw them into the chat and we'll dig into as many as we can. And with that, I'm going to go ahead and hand things over to Dr. Christopher Cooper, who is at University of Iowa, and I will let him share a little bit more about himself, as well as share his slides and talk a little bit about the basics of Duchenne and GU.
Thanks, Rachel. Hi, everyone. It's really great to be here today. Happy to talk about this topic. You know, when Angelena and Dan and I and Rachel and Alexis were speaking earlier, one of the things that we mentioned is that although we may have some expertise in this topic, nobody is actually an expert because there is so much that's unknown. And so with that sort of as a disclaimer, I'm going to now try to share my slides. So what I thought I would do for my portion is to go through a couple of studies that we put out. This first one was probably put out about 9 years ago, and it really is just looking at the incidence of different urologic manifestations in Duchenne muscular dystrophy. And the first study really is a chart review of patients that we had here at the University of Iowa. The second study will be a little bit briefer because it's somewhat redundant, but it was based on a survey that we did probably six years ago, something like that. Then I'll turn it over to Dr. Edwards, and she's going to speak a little bit more on the incidence of some of these things, but also talk a little bit about normal and abnormal. Voiding and voiding dysfunction, and also the treatments that are available. And then finally, we'll turn it over to Dr. Dan Wood, and he will talk about some of the transition going from childhood to adult and some of the issues there. So again, this was a study that I did along with a couple of the residents in our department, Kathy Matthews. Many of you may recognize her name. She's an expert in Duchenne muscular dystrophy and is a pediatric neurologist. And Brad Erickson was can't remember at this time if he was a resident or a faculty member. And so, as you all know, Duchenne muscular dystrophy is an X-linked recessive disorder, and it involves progressive loss of muscle strength and complications involving multiple organ systems. Over time, the improved respiratory care has actually extended life expectancy. And because of that, as you'll see, we're starting to see more urologic manifestations because patients are living longer. So we reviewed the charts of 135 children who had either Duchenne or Duchenne-Becker variation of muscular dystrophy. We looked at a few other things, such as their ambulatory status, their respiratory status, medical and surgical history. And as I'll show, some of these are markers of progression of the disease. And again, I know you all are much more of experts in this area than I am. But we then focused on sort of urologic diagnoses, a little bit on interventions and follow-up. So when we look back through the charts, the mean age at diagnosis was about 4 years of age. The mean follow-up that we had, or the mean age at the last follow-up was 15 years old. Most of the patients were white, which goes with the population here in Iowa. As you can see, about a fifth had died during the follow-up period, and the mean age of death was 19, whereas close to 80% were still living, and their mean age of follow-up, as you might imagine, was a little bit younger, and that was 14. And you can see about 3/4 had Duchenne, and then about a fourth had Becker. So we identified 35 different urologic diagnoses, and half of patients had at least one diagnosis. So voiding symptoms was the most common. And by voiding symptoms, if you look down at the caption or whatever we call it, this area at the bottom of a table, it talks about some of the different types of voiding dysfunction that we included. So dysuria or burning with urination, urinary frequency or inability to get the urine stream started, which would be hesitancy, incontinence, producing a large amount of urine is polyuria, urgency, so somebody got the urge to urinate. Nocturia is just wetting or need to pee a good bit at night, so it's interrupting the sleep. A weak urinary stream or feeling like the bladder doesn't empty out all the way, or flat out urinary retention, meaning they can't get the urine out at all, or post-void dribbling. So all of those we lumped into voiding symptoms. Bedwetting or enuresis was present in about 20% of patients. Nephrolithiasis or kidney stones were present, as you can see, about 6%. Undescended testicles, cryptorchidism, about 5%. Blood in the urine, and infection in about 5%. If you look at all those diagnoses, one of the things we saw is that as the disease progresses, the chance of having it was higher, and it was significantly higher, and that's what the p-values listed there are indicating. So a p less than 0.05 would be a significant difference. So if you had progressive disease and were non-ambulatory, or had a diagnosis of scoliosis or spine surgery, or needed invasive respiratory support, all of those things were associated with a higher incidence of urologic diagnoses. If we just look at voiding symptoms, this graph starts out when the patient's essentially at, 0 years of age. And then on the left side, the chance of having voiding dysfunction. And what it shows, again, is just over time and as years go by, there's a higher and higher chance that you're going to start to develop some voiding symptoms. And so half of the patients, the median age, if you will, had developed voiding symptoms by 23 years of age. In addition, again, not surprising, because with age, the disease often progresses, as you all know. And from that graph, it also the markers of advancing disease or disease progression were also associated with voiding symptoms. So again, not terribly surprising based on the graph that we just saw. I mentioned stones, and that also progressed with sort of disease progression, but there are certain factors that increase your risk of stones. And so one was non-ambulatory status, and that probably relates to potentially some bone reabsorption or other treatments that are going on with disease progression that increase the risk of stones. Enteral feedings was significantly associated with stone formation. And again, that may be related to perhaps decreased free water or the contents of the feedings that may predispose to stone. Or again, it could just be another marker of disease progression, and some of these start running together. And the same with invasive respiratory support. And again, pointing out that as the disease progresses, any of those markers of progressive disease were associated with increased risk of stone formation. So conclusions, the first one, you all know this. This is a multi-organ system disease, but one of the things that's relatively new is how prevalent it does affect the urinary tract, especially as the disease progresses. And half of the patients by our chart review had a urologic complaint. Ultimately, we think as patients are living longer, they may benefit from urologic referral. So to study this a little bit more, I'm going to cover the second study we did back in 2016. And instead of a chart review, we sent out a survey. The authors on this were sort of the same group. And we wanted to know not only what was the frequency of lower urinary tract symptoms, so voiding dysfunction type of things, but what did patients say as far as, is this a problem? Did it affect their quality of life? And so we distributed a survey. We had some sort of symptom scores on that as well, and then the quality of life questions. I've just got a couple more slides, so bear with me. I'm just going to walk you through it. We had 56 respondents. Again, average age here was about 15 years, and you can see the age range there, anywhere from 4 to 33 years old. 70% or over 70% had some lower urinary tract type of symptom. And the most common symptoms were urinary urgency, as well as hesitancy of stream. And Dr. Edwards is going to talk a little bit more about hesitancy of stream and when that typically presents. The other thing to note, bladder and bowel often work together or don't work together. And so if you've got constipation, it often impacts the bladder, and you have some significant bladder dysfunction, if you will, or bladder symptoms. And over half of these patients mentioned that they had constipation. The graph below, or the chart below here, just shows some of the common urinary tract symptoms and the percentage there. And so urgency again and hesitancy, as I mentioned, were both over 50%. Interestingly, only 2 of the 56 patients, so 2-3%, were taking any medications for urinary symptoms. However, about 40% were taking medications for constipation. When we asked them, quality of life type questions, like if you had to spend the rest of your life with urinary symptoms, how would you feel? Would you be happy, mostly satisfied, or dissatisfied? Most over about half said it's all right. I can still be happy. 19 out of the 56 said mostly satisfied, but 9 or 16% said they were dissatisfied and would like something done about it. So conclusions, pretty self-evident here. A high percent of patients do have urinary tract symptoms, but when you push and say how problematic is this, only about 16% say they're dissatisfied. We think that there's probably things we can do, and again, Dr. Edwards will talk about some of the things that can be done. But for that 16%, we think they probably should be seeing a urologist and at least discuss the pros and cons of various treatment options for some of these conditions. And this was, to our knowledge, the first prospective study. And we thought, this can serve as a baseline, but it's a relatively small number. Again, only 56 respondents. Ultimately, we would like to study this further, with a much larger population. So with that, I'm going to try to stop sharing the screen so that Dr. Edwards can take over.
Hello, good afternoon. My name is Angelena Edwards, and I work with Dr. Christopher Cooper at the University of Iowa. And so I am going to go ahead and share my screen. Okay, wonderful. So I'm going to focus a little bit more on not really talking about kidney stones or urinary tract infections, but focusing more on the lower urinary tract symptoms that patients can experience, such as incontinence, retaining urine or inability to empty the bladder, the feeling of urinary urgency or frequency, or hesitancy, difficulty getting the urinary stream started. So much as Dr. Cooper had mentioned, when doing a literature review for Duchenne's muscular dystrophy or Becker muscular dystrophy and urinary symptoms, there's not a whole lot. I mean, definitely under 20 studies that have good patient volume that you could potentially draw some conclusions for. And not all the information says the same thing. So it comes to the same conclusion of why patients may experience urinary symptoms. So I would say we don't know enough and we need to know more to better take care of patients with muscular dystrophy. And so one of the studies that I found a lot of value in reviewing was a survey done with 199 Dutch male patients with Duchenne's muscular dystrophy. And in this study, they did a similar study in the sense that they surveyed patients. So 85% of patients reported that they had at least one urinary symptom. Most reported dribbling after urination, straining to urinate, the feeling of incomplete bladder emptying. But when you look at the younger patients, so 4 to 5 year olds, they were more often would state they have decrease in their bladder sensation, or they urinate more often at night, or experience incontinence in comparison to the 19-year-old patients or more adult patients. Those patients experience more voiding symptoms, meaning straining to urinate, the feeling that they may incompletely empty their bladder, or a poor urinary stream. In this study, 18% had recurrent urinary tract infections, and 9% received evaluation for their symptoms. So a high percentage of patients are experiencing symptoms, but once again, similar to what we saw here at the University of Iowa, a lower percentage of patients are actually getting care for these symptoms. And so if we sort this by age, just like I briefly mentioned, the younger patients are experiencing more symptoms with the storage of their bladder, their bladder when they're not trying to urinate. The older patients are experiencing more symptoms related to urination. And so in this particular study, since they've had so many patients, 199 gentlemen with Duchenne's muscular dystrophy, they sorted by age, and then they looked, is the patient wheelchair bound? Do they urinate in a sitting position or a standing position? Do they need assistance with transferring or with urination? And they really found loose associations with the degree of bother to the patient. But in their discussion, they felt maybe this is due to patients experiencing more than one of these differences. And so some possible explanations that they brought up is potentially incontinence in younger children may be related to delayed toilet training or learning difficulties in the patient. Some patients may put off urination or have underlying bladder bowel dysfunction or dysfunctional voiding and constipation. They also brought up the potential hypothesis of functional incontinence, meaning it's difficult to transfer to the restroom or the need for assistance to use the restroom. And then potentially some changes that are occurring due to the muscular dystrophy at the level of the bladder, the external urinary sphincter, or the central nervous system. And so we just want to talk a little bit more about bladder bowel dysfunction. So this is a study that included 57 patients with Duchenne's muscular dystrophy and 56 healthy control patients, so children without Duchenne's muscular dystrophy that were age matched. So the patients are similar ages. And in this, 74% of the patients had at least one urinary symptom, but healthy children for the same age, 56% of patients also said they had a urinary symptom. And so 68% had bowel symptoms, and 39% of healthy controls said they had a bowel symptom. But more importantly, when you look at the combination of urinary and bowel symptoms, Duchenne's muscular dystrophy patients experienced 53% of them reporting having a symptom in both categories in comparison to 30% of controls. And so I just want to talk a little bit about bladder bowel dysfunction, because this is something that impacts children that do not have muscular dystrophy. We see a high percentage of children in clinic that have a multitude of different urinary symptoms or different urinary bothers. Incontinence, leaking urine during the day or night, having urinary accidents, delayed toilet training, painful urination, blood in the urine in a young child, constipation, fecal incontinence, or leaking stool. These could all be reasons that a child would see a pediatric urologist. So we just want to talk a little bit about a little bit about that, and then how it may relate to Duchenne's muscular dystrophy. And so in a healthy bladder, and in a normal relationship of bladder storing, the bladder should be completely relaxed. The muscles should, and the urine should be able to be stored at a low pressure. And the external sphincter muscle, the muscle that controls the bladder, should be able to be squeezed and closed. And so the patient's dry when they don't want to urinate, but when they want to urinate, the bladder, the external urinary sphincter muscle should relax completely. And the bladder muscle should squeeze to allow complete bladder emptying and a good urinary stream. Well, not everything always happens, correctly or in a synergistic pattern for every patient. And so some patients may have overactivity of their bladder, meaning they have squeezing that's happening while their bladder is trying to store. Some patients may have incomplete relaxation of their external urinary sphincter. So when they're trying to urinate, they can't get a good urinary stream where they don't completely empty, or the squeezing of the sphincter muscle and the bladder are trying to happen simultaneously. And those patients may have elevated bladder pressures or may even be at risk of injury to their kidneys. And so how does constipation play into this? And so this is a cartoon we commonly show, at least in our clinical space, to help children understand why they may, why it's important we're asking them about their bowel movements, is if there's a lot of stool burden in the rectum or retaining stool, that can easily, push on the bladder and cause bladder irritability, low volume urinary leakage, painful urination or incomplete bladder emptying, or it may be a hydration problem. The child's not drinking enough water to have nice soft bowel movements or have diluted urine that wouldn't cause any discomfort with urination. And so sometimes we do a test in urology called Urodynamics. This is an invasive test in the sense that the patient does require catheterization. So we put a small catheter in the bladder that has a pressure probe. We put a small catheter in the rectum that also has a pressure probe, and then we place some stickers on the perineum, kind of outside of the anus, so we can see what the pelvic muscles are doing. And the reason I wanted to bring this up is really to describe some of the patterns that have been reported in the literature for patients with Duchenne's muscular dystrophy on what their bladder is actually doing. And so in a study of 9 patients, the average age was 7 to 14 years. So these are school-age children. Of those 9 patients, 8 of the patients had bladder overactivity. So their bladder was giving little squeezes while it was supposed to be relaxing and storing urine. 7 of those patients were found to have a small capacity bladder. So we can calculate the size of the bladder it should be based on the patient's age. And in this study, 7 of the 9 children had a small capacity bladder. 1 patient had bladder overactivity, and this DSD here stands for detrusor sphincter dyssynergia, meaning the detrusor is the name of the bladder muscle, the sphincter, and they're dyssynergic, meaning they had that pattern where the bladder is trying to squeeze and the sphincter squeezing at the same time. In that patient, though, they had a spinal surgery, and so that's a little bit difficult to know if it was strictly related to their Duchenne's muscular dystrophy or because they've had a spinal surgery. In this study, all 7 patients that had a small capacity bladder started a medicine called oxybutynin, which is a medicine that helps relax the bladder. And they had an improvement in their urinary urgency, frequency, and incontinence. And so another study was 6 patients with Duchenne's muscular dystrophy, but these patients were older. These were young adult men. Average age was 25. And they had a normal bladder capacity in this study. And 1 patient had bladder overactivity, but half of them had that dyssynergy of their bladder trying to squeeze at the same time the sphincter is. And so that's a little bit different than what was seen in a study with just a few years older patient, if you will. And then lastly, I wanted to include the only published I could find on Becker's muscular dystrophy urodynamics features. And this patient was a 20-year-old male that had bladder overactivity but had normal voiding. And so some of the hypothesis of why Duchenne's muscular dystrophy patients may have bladder bowel dysfunction or difficulties with urinary incontinence, hesitancy, frequency, or constipation is they've actually started to see that the dystrophin expression is present in smooth muscles. So the bladder is a smooth muscle. and some of the afferent nerves. Those are the nerves that carry signals away from an organ, like the bladder, carrying signals to the central nervous system. And they saw this in rat bladders. So the fact that they see that there means that, you know, potentially that can lead to further discovery of why this may be happening. But if you hypothesize that that is the problem, over time, the bladder muscle would fail. It become kind of flaccid, or it should be able to be a very high capacity, means holds a lot of urine, but probably unable to empty completely because it doesn't give a good bladder squeeze. And that's not the pattern that's been reported in the literature, at least in these patient age groups that are closer to the pediatric age. And so at this point, that's a little bit of a different presentation than what we've seen in other studies. Boston Children's put a paper out quite a while ago where they had 7 children. And 5 of those had a pattern of what they call upper motor neuron, meaning that they had that dyssynergy in between the bladder squeeze and the sphincter muscle. And they had some bladder overactivity. And so they concluded in this that they felt like that may be related to Duchenne's muscular dystrophy patients all having more severe scoliosis. And in this group of patients, everybody having a spinal fusion. But in that paper we talked about earlier, the Dutch study, they were unable to correlate spinal surgery with urinary symptoms in their study. And so you can tell each place that studies it, it seems like we're getting a little bit different results on the why. And I think that's why we really need to do some prospective, meaning getting a group of patients and following them over time so we can better tell what's going on at the level of the bladder to really help improve the care for Duchenne's muscular dystrophy patients. The last is some combination of all of these things involved. Bladder bowel dysfunction is common in children that don't have muscular dystrophy. And so there's a chance that some of the things they are experiencing is some of the normal patterns we see in children that have daytime wetting, delayed toilet training, or bedwetting, and unrelated to muscular dystrophy. The patients with muscular dystrophy may have some waiting to go to urinate because they may be in a wheelchair and need assistance for transferring. Some patients may experience worse constipation. And so, you know, there's probably a constellation of reasons why, but for us to tell you, we know exactly why it's happening, I don't think we know yet, but I think the good news is there's a lot of things we can offer. And in the studies that are out there, when we do start some of these treatments, the quality of life improves for the patient. I will stop sharing.
Thank you, Dr. Edwards. That was fantastic.
Okay, so I'm going to start sharing my screen. I'm really grateful to be involved in this and was very honored when I was first contacted to be part of this whole project. Chris knows me very well and remarked before we started that I'd still be preparing my slides. I'll show you why that's important after this slide. You'll gather that I don't sound entirely like everybody else on the call today. That's because I originate from the UK, where I trained at St Bartholomew's Hospital, right in the centre of London, and I did most of my training there. My PhD looked at true smooth muscle and the physiology of it. So that's a bit of background as to why I have an interest in this. And I grew up and then was appointed as a consultant or attending in central London and used to work with the team at Great Ormond Street. And we led some consultations looking at congenital urology and how that progresses through into lifelong care. Just over a year ago, I was appointed to and moved to the Children's Hospital of Colorado and the Colorado University Health System here, which I'm very excited to be part of. So I put this slide in while Dr. Edwards was actually talking, because I think there are just some important messages to think about based on what you've already heard. That it's really important to recognize that through improved respiratory care and the surrounding support, that survival's improved. That's a massive step forward and a really important landmark. It means that it presents us with new challenges that we need to think about and where we can prepare for. And it means that we don't necessarily understand the effect of aging. And it means that from some of the data that's been presented by both Dr. Cooper and Dr. Edwards, that some of the urological symptoms and the consequences of those are unpredictable, just because we've not really seen them in adults and adulthood, and therefore being aware of that and understanding that in how we take this practice forward, I think is really important. So when I started my job back in 2008, when I was a consultant in London, really we were kind of divided into phases: pediatric adolescent care and then adult care. And actually over the course of my career, we've seen a much closer working across the spectrum. And I think this session in itself demonstrates that. And what I'm going to talk to you is less specific to the urology side of things and more specific to the side of thinking about an approach to adult care, both in Duchenne's and other congenital conditions. So the importance of transition is that we're starting to see an improvement or a recognition of improvement in long-term health care outcomes as a result of doing that. So transition really is all about making sure that when somebody reaches their young adult time and they're starting to want their independence, that the healthcare system recognizes that and supports that. And that they have autonomy, particularly in their kind of healthcare decisions and how they're going to be looked after going forward. And independence means a variety of different things to a variety of different people. Some people will want to live very independently. Some people want to make independent healthcare decisions, but within perhaps a more supported environment. So it's all encompassing in that sense. There was a report this year that recognizes the difficulty in showing positive data for healthcare outcomes in transition across all specialties. But we're certainly starting to see that patients want it, parents are keen to support it, and the healthcare environment benefits from it, because we start to see, for instance, reduced attendances at emergency rooms where patients are well looked after within a healthcare setting. So there are some important elements around transition. There are lots of reasons why transition is important. We know that most importantly, that actually if people are part of a good transition service where they're given some form of a plan as to what their healthcare might need to be going forward, that they've got, that they're well prepared for that transition into a more adult healthcare environment, and they hopefully have got a supportive provider of the future, that the dropout rate from healthcare is dramatically reduced. And so keeping people in the healthcare system gives them access, and when new problems arise for them, it allows us to think and tackle that. There are all sorts of aspects of why patients have different priorities as they become older versus when they were a child. And those can vary enormously from an individual. But the most important thing is that when it's needed, they have some privacy to be able to discuss things that they're concerned or worried about as part of that ongoing care. And family support is immensely important for all of our patients. But in terms of healthcare, healthcare independence, it's important that there's a recognition of a shift in control in decision making. That doesn't mean that family can't support that, but that there is an increasing emphasis on a patient themselves making their own decisions. And there are lots of examples of this type of work in transition. But this is one, just about how and when we should start thinking about preparing patients for that kind of independence. And this is really designed to make it seem a little less scary. I think a lot of people reach the end of their pediatric care, and it's terrifying that they outgrow their pediatric healthcare setting and that there might be no one there to look after them. Well, this recognizes that. It recognizes that building somebody and their confidence, their own confidence in being able to ask questions when they come to see anyone in healthcare, think about how they might want to set their own goals and make those decisions is really important. And it begins by building their confidence, understanding that they can talk about their own diagnosis, ask their own questions, perhaps initially with their parents, but then as they go further and further on, they'd be asking their own questions in their own consultations and so on. So we've seen some of these data already. This is presented just slightly differently, but it illustrates the fact that from a urology point of view, we know that a number of patients affected by Duchenne may well go on to demonstrate lower urinary tract symptoms. And that's important to recognize, whether you're a patient, you're a parent, or part of the healthcare community that's going to be receiving these patients and thinking about looking after them going forward. Dr. Edwards presented very eloquently a number of studies that show problems in young adults, but we could see from those data that the numbers are very, very small. And we'll start to see, I suspect, an increasing the number of patients over time. And so I hope that collaborations like this will give us opportunities to look in more detail and to research that population better. But at the moment, our understanding is a little bit rudimentary. This was, again, a recognition of some of the things you've seen before, but taken from a different paper that showed that actually a lot of these patients, about 18%, had bigger bladders than we'd expect, that they didn't empty their bladder in the way that we'd expect. So they had those abnormal flow curves, that they couldn't empty their bladder as well as we'd expect. So about a quarter of them had more urine left behind in their bladder. And about 30% of them in this study had an abnormality or one or the other, or one of the others of those factors. And that's just one aspect. That's just looking at how we might take measurements on the basis of somebody passing urine. So it gives us an insight into the importance of being able to look at that in more detail. A urologist can't do this all on their own, and it's really important to recognize that if you go and see a urologist, you will still need to carry on seeing other people as part of that multidisciplinary care, and that we're there to help and support that care, and just one aspect of that care. Many of us are used to working in what we call multidisciplinary teams or multidisciplinary clinics, and that's, I think, hugely important for patients, that we have that continued dialogue between disciplines to try and A, understand why something might happen, and then B, to help to try and provide the best solution. So in terms of adult urology and how we might think about it, I think things for us to think about that we should watch for, you should watch for, and why things might change from a urological point of view are things like some of the things that have been highlighted already: urinary tract infections. If we see changes in bladder function, so somebody going to the toilet more frequently, somebody who becomes incontinent, or there's a change in continence, whether that's day or night. Other symptoms such as blood in urine that might, for instance, represent a urinary tract infection, or some other manifestation of urinary stasis, such as stones either in the kidneys or the bladders. And the sorts of things that urologists will be working towards in terms of investigations are some of the things you've seen already. So how well you empty the bladder, both in terms of the speed of emptying, a uroflow, and the efficiency of emptying. So a bladder scan, is there urine left behind in the bladder? If we're worried about the detrusor sphincter dyssynergia that Dr. Edwards was talking about, then we may start to look at the kidneys and how they're functioning. We can do that through blood work. We can do it through ultrasonography. And if we want to better understand the detail around bladder function, then we'll undertake urodynamics, which again, Dr. Edwards showed you some pictures of, measuring pressures in the bladder so we can actually see how it's working. And occasionally it becomes important for us to understand that there isn't other pathology in the bladder, or to understand the anatomy of the system, and cystoscopy and sometimes other forms of imaging can be employed to help with that. So the sort of things that we may discuss are really related to a balance of the risks of treatment versus the benefits of treatment. And that's true for anyone in a healthcare setting. We're constantly evaluating what's happening to you, thinking about what we could do about it, and thinking about what the good things and the bad things that might arise from offering you those treatments. So there may be times when, yes, you have some symptoms. Yes, we can recognize that you're, for instance, not emptying your bladder completely, but actually, if you're not getting significant problems as a result of that, that you're not getting, for instance, UTIs or other symptoms that are really bothering you, at that point, we may say, well, look, at the moment, we're going to hold back on offering you treatment, or you may decide that you don't want treatment because we think the risks outweigh the benefits of that treatment. We may think about some medication, either to relax the bladder neck to make it easier for you to empty your bladder, or to relax the bladder if there's a lot of urinary frequency. We may think about emptying the bladder by periodic catheterization, or indeed leaving a catheter in. There are lots of things that we could do beyond that. These are just some of the examples, if you like, as a starting point for the discussions that we might have around treatment of the urinary tract, particularly in adults. And we'll start to develop our understanding as we see more and more patients come through as to what the evidence is behind each of these treatments in older patients with Duchenne. So it is true that at the moment there's very little research in this area, particularly in older patients. But I'm hoping that, as I said earlier, some of these areas will develop by collaborations such as we're seeing today. It is also true that urologists are very familiar with a set of good urological principles in terms of how we treat a bladder when we think it might not be emptying, what we're worried about in terms of pressures in the bladder, looking after the kidneys and making sure that we observe those carefully. So if you have concerns, see a urologist. We're very happy to see you and discuss what might be happening, why it might be happening, and what we might do about it. And if you're not seeing a urologist, or you are seeing someone who doesn't seem to give you options, it's your body. So don't be scared to ask questions and find out what your options might be. So you may need a urologist involved in your care. Adult care might look a little different to pediatric care. It doesn't mean it's worse. It just means it's different and the environment is slightly different, but turn up and ask questions and most people will be very happy to help you. Thank you very much. I'm going to stop sharing.
Wonderful. Thank you so much, Dr. Wood, Dr. Edwards, Dr. Cooper. I know I learned so much. So at this point, we'll go ahead and we'll pivot to an open question and answer session. I do see that we have a handful of questions that have come in through the chat. So I think we can go ahead and just start at the top. I also have a couple of questions that came in by email that maybe we'll start with those ones. If our discussion prompts other questions, feel free to throw those in the chat. We'll get through as many as we can in the next 15 minutes. And if there are any questions that we're not able to get to, we will absolutely follow up with you after today's webinar and make sure that you get the information that you need. So the first question I have is in regard to incontinence. So given that this is a muscle wasting condition, as it progresses, will there ever be a time when the person with Duchenne would become incontinent? Does it affect the muscles involved with normal urinary and GI movements? So I'm thinking probably either Dr. Cooper or Dr. Edwards. Do you want to talk about that a little bit?
Well, hopefully we've covered some of that. As you saw, there is, with time and with progression of the disease, an association with more and more lower urinary tract symptoms, as well as stones or other complications. And I think Dr. Edwards sort of touched on, well, there are different hypotheses of why this may occur, but in reality, we don't know for sure. And in each person, it's probably different. And yeah, there are some tests that can be done, like urodynamics, as Dr. Wood just mentioned, or other tests to investigate further that might guide therapy. So it's hard to just say in general, this is what should be done or what would happen. But we can say that, yes, with time and progression of the disease, we do see a significant increase in the frequency of symptoms. Again, the other thing I'd point out, though, is despite the increase in symptoms, 80% or so said, I can live with this.
Really appreciate you bringing it back to the quality of life component. I think that that's really critical. Dr. Wood, would you add anything?
No, and I think the last point is perhaps the most important, really, that actually understanding what a patient wants or what is affecting a patient most makes a huge difference in terms of how we're going to make decisions. And so don't be concerned or intimidated if you're given a number of options. You're usually going to have what I describe as the luxury of time and choice. And that means that you've got time to go away and think about what your options might be and then make a decision. There are very few circumstances in this type of situation where you have to make a decision on an urgent basis.
Wonderful. All right. So my next question is in regard to bedwetting. So we have a 12-year-old with some ongoing bedwetting. He is ambulatory. In that scenario, would you recommend that the family seek out the advice of a urologist? And what sort of testing or treatment might they ask about?
I'm happy to take this one. I'm unmuted, so I'll take it. And so for bedwetting, outside of Duchenne's muscular dystrophy, one of the first things I ask is if there's a history of bedwetting in the family. So we know some families do have it. It gives us some idea. Also, we ask a lot of questions about sleep habits, if there's the presence of sleep apnea, if they're on any medications that can cause bedwetting. And then we kind of work through that in a stepwise fashion with each individual to see if there's something we can change alive or wetting. We always check and make sure, especially if it's new bedwetting, it's primary, meaning it's always been there, the child's never been dry. That can be different than reasons that somebody that is continent at night now has new wetting. And so we do some tests to make sure we're not missing something new. And then we walk through it and see what the bother is for the patient. If this is something that bothers the child, there's different ways to treat bedwetting. There's behavioral therapy, and you really optimize how you're urinating and stewing and hydrating. And that's different for everyone. And then the habits that you do when you use the restroom, those types of things before bed. There's bedwetting alarms, there's medication. So there's a lot of options. So I think if it's something that is concerning for the individual, seeing a pediatric urologist, especially, I think almost all of us are very happy to see anyone that has any type of wetting, especially bedwetting, to make it a quality of life improvement for the child.
That's wonderful. Thank you so much, Dr. Edwards. All right, this next question kind of crosses into GI and GU a bit, and I know that you all kind of acknowledged that there is some crossover there. And this is something that I hear a lot about from parents, and it's in regard to potty training. So the question reads, I'd be curious to know the typical age and challenges regarding potty training in Duchenne. My 7-year-old who has Duchenne appears to not know when he needs to go. So he'll go if we take him, but he's still having some difficulties. What would you share on that topic?
Go ahead, Dr. Edwards.
So I very similar, this is our specialty when it comes to toilet training, and it's not uncommon, even outside of Duchenne's muscular dystrophy, for us to see a 7-year-old that's having difficulties with toilet training. The fact that your son is able to, hopefully he's generating a good stream and voids a decent amount when he's able to be taken to the toilet. That's a good thing. That shows us that he is, able to use the restroom on command, but may have differences in sensation, and that can be from a behavioral, or it could be related to his Duchenne. So I think that would be, if it's something you would like further assistance on and advice on toilet training, it's different for every child. Seeing a urologist would absolutely be beneficial. And if there's underlying constipation, we see children that have constipation, cleaning with defecating, any of those things, they sometimes have delayed in stool training, yet they're continent of urine. And so one of the first things I do with families is really look into the stool consistency, the frequency, understanding that for the family, so I can help that child achieve stool continence. So we can be a multitude of reasons for the toilet training to be effective.
That's really helpful. We actually just got another question that kind of extends that conversation on bedwetting into young adulthood. So the question is, I've had bedwetting since I was 7. I'm now in my early 20s. I'm still experiencing this difficulty. What do you recommend? It's paired with severe urgency. Is this something that you would treat similarly, or once we get into young adulthood, how would you change those recommendations? I don't know, maybe Dr. Edwards or Dr. Wood.
Yeah, I mean, I'm happy to take that. I think it's important to as I was kind of saying earlier, go back to really basic urological principles and understand exactly what's happening to your bladder. A lot of the discussion that we've had throughout the webinar has demonstrated that the urology underlying your symptoms can be slightly unpredictable, and therefore seeing a urologist is important to evaluate that in a bit more detail. because it may be that you are struggling to empty your bladder and this is kind of an overflow type incontinence. It may be that you have an underlying overactivity to the bladder where it's firing off in an uncontrolled way. And those two conditions or those two situations would be treated very differently. So seeing a urologist and having it evaluated formally at this stage, I would suggest is important. And the situation may have changed from when you were 7 to when you are now 22. So like a new baseline becomes really important, I think, in establishing what's actually going on for you.
Excellent. And then another semi-related question in regard to external catheters. I know that especially in our young adult population where mobility changes are very prevalent, this is something that comes up pretty frequently. Do you have any recommendations on external catheters or other types of interventions that can be supportive in independence and activities of daily living?
I don't know if Dr. Wood, since he made some more adolescents and young adults than myself, but definitely condom catheters for male patients is an absolute option if mobility is an issue, or dexterity. That's a catheter that does not go into the urethra, but it's a device that goes over the penis and allows that gentleman to have independence and dryness because the urine drains into a bag, and it can be concealed under the pants with a leg bag or off of the wheelchair. And so that would be an option. There's a lot of different urinals, and that's an option too for the patient. So I've met multiple young men that prefer a urinal, and you can find a way to have it attached to the wheelchair that's convenient for that gentleman. So those would be options to urinate but still stay in your chair and not be or
Sometimes we've done reconstructive type surgery so that the patient can pass a catheter basically through their belly button, and it goes down and drains the bladder that way. Usually that involves taking the appendix and connecting one end to the bottom of the belly button and the other end into the bladder. And for a variety of reasons, in some patients, that is easier, as you might imagine, to pass the catheter through there. There's no sensation. Also, when they're in a chair, it's easier just to pull the shirt up, and they can still sit and drain that way, as opposed to having to get more recumbent or have somebody else catheterize them.
Thank you for sharing that, Dr. Cooper. I think it can feel a little bit difficult to talk about some of these invasive types of interventions, but at the same time, I think that it could be really transformational in the right person, in how it can really promote independence and being able to manage these things out in the community without having to request assistance and transferring in and out of your chair and some of the other difficulties that can come with limited mobility. So I really appreciate that. It sounds like there's a whole host of options that somebody could really bring to you as a clinician and say, like, this is where I'm at. What's the right solution for me? And it's probably different for everybody, right?
Absolutely.
All right. So my next question is in regard to side effects of medications. And I think that this is one that we hear pretty often, especially from families who start steroids. They notice an increase in frequency or accidents in their younger kiddos. So can we talk a little bit about how medications can contribute to urinary issues like incontinence and such as whenever medications may change, especially psychiatry medications? I find that sometimes with medications, my son is aware of urges, but he does have more accidents as a young adult with Duchenne.
Dan?
So I think there are clearly two aspects to this. First of all, there's discussing what medication you're going to start with the prescriber and understanding the side effects with them, because they are going to be the most knowledgeable about the particular medication under those circumstances. So whilst the end effect may be something that's urological in its manifestation, the baseline side effects may rest with the medication. The role that a urologist would play as part of a team is really to try and mitigate that and work out help working out what the balance of risk from a urological perspective is versus benefit from the drug, and to try and assist with that. So we will always help with that. But ultimately, it may be that that medication is more important for the ongoing care of a patient than some of the urological manifestations. And so we may just have to work on some clever strategies to try and help with dealing with those side effects rather than perhaps getting rid of them.
Wonderful, Dr. Wood. I really appreciate the very holistic approach that I'm hearing from each of you in terms of meeting families and patients where they are and finding a customized and creative solution depending on the ultimate cause of what's causing the issue, and then figuring out how it fits in with the lifestyle too. So I'm very grateful to hear each of your perspectives. I do want to be mindful of time. We are at the end of our hour together, and I know that we weren't able to get to every single question, so we will follow up with folks individually to make sure that we're able to get you answers to your questions. I can also share that this recording will be available within the next several days on our website, along with a post-webinar recap blog. And you can always reach out to us with any questions you have. You can email me at rachel@parentprojectmd.org, or you can reach out to the entire PPMD care team at careteam@parentprojectmd.org, and we can get you connected, get you hooked up with resources, whatever the case may be, whatever your needs are, we're here for you, and we're happy to provide as much support as we possibly can. And I also want to thank Dr. Cooper, Dr. Edwards, and Dr. Wood for joining us today. This has been really enlightening. I think we all probably have learned so much. And I know I have lots of questions that come from learning more. So I think that this will probably be the first of many conversations. And we're just really grateful for each of you for joining us, and then for everybody for joining in and listening. So thank you, everybody. And we'll go ahead and conclude today's webinar. Thank you so much.
Thank you.
Thank you.
Bye-bye.